Welcome. We'll get started in just a minute. I'm going to let a couple more people in. So welcome everyone. My name is Angela and I'm the State's Advocacy Manager with Compassion and Choices. Thank you so much for taking the time to join us today. I got started with Compassion and Choices. What drew me here is my grandmother passed away from Alzheimer's, and we didn't have a lot of conversations around end of life. She did talk to my mom, who was a nurse, but at the end of her life, she didn't have the end of life experience that she wanted. And really, my mom, there was a big family fight, and my mom is still very upset about it, like almost a decade later. So I'm so glad that you took the time to join us today and want to learn about having these important conversations. So after we go through an introduction, we'll go over some important advanced care planning, what it is, what documents you may want to have, what end of life options are available, tips on how to have the conversation, and then a few additional resources that may be helpful, and then we'll have time for Q&A. So Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everybody to chart their end of life journey. And so this is our mission statement. We believe in patient-directed care, where patients should have the ultimate decision in choosing their treatments that align best with their individual priorities. Patients and healthcare providers should work as a team. Your healthcare team should not be just making decisions alone. So this is a quote from the book Being Mortal. And it says, life is meaningful because it is a story, and in stories, endings matter. Research has revealed that most people want an end of life experience at home with their pain and discomfort managed, to have their spiritual needs and values respected, and without being a devastating burden to their loved ones. However, in reality, 60% of Americans die in acute care hospitals and another 20% in nursing homes. 1 in 3 near the end of life receive non-beneficial treatments, which are often painful, uncomfortable, and futile, with no hope of improving health while compromising quality of life. So what we want to talk today about is really the gift of end-of-life planning. Advanced care planning gives you the opportunity to have an end-of-life experience that matches your values, priorities, and beliefs. It gives you the chance to reflect on what's most important to you, to decide what kind of care you want or what you don't want at the end of life. And it gives your loved ones a way to implement critical informed decisions on your behalf, free of guilt. Not having these conversations can often leave your loved ones in disagreement, confusion, and grief. There's a lot of evidence behind the benefits of advanced care planning, and it shows that it promotes patient-directed care by focusing on what the patient or the person wants, that it reduces the decisional burden of the loved ones as to whether or not they're making the right decisions that align with the person's preference, that it improves the bereavement experience of loved ones by reducing stress, anxiety, and depression, that it decreases in hospital and intensive care unit deaths, and reduces the cost of end-of-life care without increasing mortality. And now I want to introduce Kim Holland. Kim is a volunteer with us. She lives in Iowa, and I heard her share her story about her experience with her mom at end of life, and asked her to join us today to share it. And I hope that you all learn from it and are inspired by it. So thank you, Kim, for joining us.
I'm happy to be here and happy to share, and hope that this might ring some bells for you. So background on my mom, Lois, a registered nurse whose nurses training took place in Rochester, Minnesota. Dad and mom put down their roots in our small town on the border of Iowa and Minnesota. After kids arrived, mom stopped working at the hospital to get us launched. Once we started school, she worked part-time at the local nursing home. Life was busy. She was what we call in the Midwest a church basement lady, who could tie a quilt, serve a funeral or wedding, teach Sunday school, deliver Meals on Wheels, as well as help with Girl Scouts and with Red Cross blood drives. Mom faithfully walked several miles at 5:30 almost every morning. She loved teaching needlework classes at our local craft store. Mom's mother, my grandma, had dementia. Grandma entered the local nursing home where Mom worked, and eventually Grandma was unable to care for herself in any way. Grandma spent her last 10 years curled in a fetal position, not knowing a soul or recognizing whether it was day or night. Nurses' aides spoon-fed her for 10 years in this condition. A phrase I remember Mom saying was, "What's so great about living to 93 if the last 10 years were spent in a void?" Without a doubt, dementia terrified Mom. She had had a lot of years to think about it. She feared the same existence her mom had endured. After Dad died and was no longer able to speak for her, she knew she needed a document to outline her wishes. Mom explained to our family attorney she did not want an end like her mother had. An extremely clear advance directive was written, including what she did not want for her life. The quality of her life mattered more than the number of years she reached. She distributed her advance directive to her 3 kids, her sister, and her doctors. Mom told us, "Keep this where you can always find it." Mine was in my sock drawer where I saw it every morning. With the advance directive completed, Mom traveled overseas several times with friends and continued to volunteer, teach classes at the craft store, and do lots of copying with her friends. 10 years later, my husband and I had moved from Oregon to Minnesota. I was working on a college campus, and I vividly remember receiving a phone call from the chaplain's office, which was unusual. The secretary told me that my mom had been life flighted to Rochester and the situation was grave. A word I will never forget because it carried so much weight. I scrambled home and pulled out Mom's advance directive. We drove to the emergency department of the hospital, and there 2 doctors had conducted tests on Mom and explained she had suffered an aneurysm in her brain, and on a scale of 1 to 10, the severity of hers was an 8.5. I shared with them that Mom was a registered nurse and always told us she would move to Oregon if she had a terminal diagnosis. She wanted to have control over her suffering. The 2 doctors didn't say a word, but looked at each other with a nod of recognition on what that meant. My husband and I were sent home. In the middle of the night, the phone rang. It was a nurse on the neurology unit. The nurse explained that the swelling in Mom's brain was increasing and surgery would be needed to relieve that pressure. I said I'd be there as soon as I could, but no surgery until I spoke to the doctor. Armed again with the advance directive, I arrived. Mom was in the hallway on a gurney, prepped for surgery. Naively, I asked that surgeon if that surgery would restore her ability to communicate. And that answer was no. The surgery will relieve the pressure, but not restore any functions. I showed him the specifics in her advance directive where it stated the conditions she did not want. I called my 2 brothers in Florida, and it was a quick call. We were all on the same page, no surgery. Mom would have hated to be in the condition she feared the most. It wasn't the dementia, but it was this aneurysm that had brought her to an end she feared. Thanks, though, to the advance directive, her wishes were honored. After the funeral, a note from the Rochester neurologist arrived. The note told us what a gift our mom had given her kids in being so clear about her wishes. He had seen many instances where that was not the case, and often family members had different ideas of what that patient would have wanted, and often tensions in the room ran deep. Having only been through this experience once, it wasn't until I shared our story with Compassionate Choices that I learned a note from a doctor with that message was pretty unusual. In the space of a few days, We had gone from it's an ordinary day to shocked, then saddened, and now we were adult orphans. However, one thing, we were unified in knowing we did exactly what Mom wanted us to do. And this was in thanks to that advance directive. We've all read how a terminal diagnosis can prompt you to think about your priorities, quality of life, and values. But I'm hoping Mom's example might inspire you and the people you love to go through the process of creating your advance directive just because. Sometimes you do not have the luxury of a warning to get this document prepared. Having Mom's advance directive in my hand allowed Mom to speak for herself. Put that advance directive in the hands of those who will be acting for you. You never know when that's something out of your control might happen. And we've also heard from friends of Moms that said, oh, it's okay. I've got mine. It's in the bank safe deposit box, or it's at my attorney's office. And when it's 1 a.m. and you get that call, it isn't going to be useful in those two places. So as a gift to your family and to get everybody on that same page and honoring your wishes, probably a good gift would be your advance directive. You will give them comfort knowing they honored you. And that's, in a nutshell, our fast and dramatic story of how Mom's advanced planning led to her not ending up in the same condition as her mom. So I thank you for allowing me to be here with you, and I'll be around till the end. So
Thank you, Kim. And you were not prepared for me to ask you this, but could you also just share with me what you shared about your friend whose father passed away over Thanksgiving?
Yeah. We, after this all happened for Mom, we had copies of her advance directive, multiple copies printed, and we shared those with our close friends and family. And these were my college friends I shared my copies with. And just recently, my friend's father passed away right before Thanksgiving, but because of their having seen Mom's advance directive and having had those conversations, Wally was able to have everything organized. He knew what he wanted. And for him at 93, this still had prompted how much, he had wanted to go through. And it simplified their whole process. So, 20 years later, it still made an impact.
Thank you for sharing that. I just thought that was so beautiful when you shared that with me. And really what a gift your mom was to share all this information with you. So
as a nurse, she'd seen it all and she knew what she did not want. So, having lived through what her mom, endured, it was very upfront. So
thank you. Thank you so much. What a powerful testimony to the importance of advanced care planning. So to begin advanced care planning, we want to encourage you to ask yourself some important questions. What are your values and what are your goals of medical treatment? And how do you define life? What matters most to you? Is it quantity of life? Is it quality of life? What brings you joy? At Compassion and Choices, we have a toolkit, the My End of Life Decisions booklet, and it can help walk you through this decision-making process of identifying your values, writing your advance directive, choosing a healthcare proxy, and much more. So you can download it from our website, or you can go on our website and order it, and we'll send you one of the booklets. But I'll send the link out to order that in the email follow-up with the recording for this as well. So an important step in advanced care planning is making thoughtful choices now and documenting them in your advance directive. An advance directive is a legal document that outlines your end-of-life priorities. This document only goes into effect if you lose capacity to make your own decisions. The two most common forms in an advance directive are your living will, which includes the care that you want or you don't want, and then Some states call it different. I'm most familiar with a healthcare proxy, but some call it a medical power of attorney. And this is who you are choosing to speak on your behalf if you become unable to do so. You don't need an attorney to fill this out, and in most states, it just needs to be signed in front of the required witness. Your living will include information on resuscitation and life support. However, you can also add additional information about other end-of-life care, such as how much pain control you want at the end of life. A living will may not be applicable in every single situation, but having continuous conversations with your healthcare proxy, your healthcare provider, and documenting your wishes in an advance directive will be able to best guide your healthcare team and your healthcare proxy to help you get the end of life that you want. Advanced care planning is a continuous process, and it is recommended that it's not just like a one and done thing, but that you review your advanced directive, update your preferences, and then provide new copies to your healthcare provider, your healthcare proxy, your loved ones, and ask them to dispose of your old copy. We recommend that you review your advanced directives anytime one of the 5Ds occur. So this would be anytime that there is a major family change, such as a divorce, anytime there is a decline in your health, anytime you receive a new diagnosis, anytime there's a death, especially if, it might be possible that your healthcare proxy dies first, and then you want to be able to pick a new person to speak for you. And every time you start a new decade. And then since state laws vary, you also want to make sure that you have an advance directive that goes with your state. Now, some of your advance directives might be recognized in other states, but again, it really depends on the state laws. And if you are, we call them snowbirds here. I live in Arizona. So people that live north and then come to Arizona for the winters, you might want to consider having two different advance directives, one for the state that you live in during the summer, and then one for the winter. And so we also recommend that, not just we, it is recommended that everybody over the age of 18 have an advance directive. So this particular graph is for everyone over 18, and this was done by some researchers. And they were able to tell that there was a difference in the amount of white people who had advanced directives completed versus Black, African American versus Latinos. When you look at people who are over the age of 50, the numbers look a little bit better. So it's about 44% of white Americans have completed it over the age of 50 versus 24% of Black Americans and 26 Latino Americans. So some of the reasons for these disparities can just include lack of cultural competency in the healthcare field. There could be systemic issues, within our healthcare that has kind of, lowered the amount of trust to have these conversations with your healthcare providers due to decades of discrimination. And then people also may identify with and mostly people who identify with non-Western culture, is that they may feel like it is more of the role of their trusted loved ones, their friends, and their community, such as a trusted religious leader, to make these treatment decisions rather than making it an individual side, even though they're totally capable at the time of making those decisions. And so how to choose a healthcare proxy. So you want to make sure that you're picking a healthcare proxy that really understands what is important to you, that they trust, that you can trust them to carry out your wishes, even if it differs from their own. And so that's one of the things that happened with my grandmother. She didn't really have this conversation with all of the family. And it turned out my mom and all her siblings, big surprise, had very different values in life, right? And so they were all just trying to kind of make the best, they were all trying to do the best that they could for my grandmother. But my grandmother had only really ever talked to my mom about it because my mom was also a nurse. You want to pick somebody who knows how to advocate and will speak up in a crisis. And you also want to make sure that this person will be in the right emotional state at the time to and can work well under pressure. And I'll just share before I started with Compassion and Choices, my husband had been my healthcare proxy. And after kind of going through this and reviewing it, I switched my healthcare proxy to one of my friends who is a social worker, and she's a really strong advocate. And I know that she will do what I want. And when I had the conversation with my husband, letting him know that I was thinking about changing it, his immediate reaction was like, I could just see like his hurt on his face. And I said, like if I was, in a situation where I needed life support and I wanted to be removed from it, like, would you be able to honor that? And he was like, well, no, I don't know that I could do that, and I was like, well, that's why I'm picking Michelle. And I don't want him to be in that position, and I don't want him to feel guilt over it. And again, I think it changes, who might you want to be your healthcare proxy, because my parents are in their 70s and 80s, and they're each other's healthcare proxy. But I think it can be more difficult, if you're younger and healthy, for your spouse or somebody that you like, your children, to make those kind of decisions. But again, it's totally up to who you know, and talking to them with your values and having these conversations, and then identifying who would be the best person to be your healthcare proxy. And then it's also might be a good idea to make sure that they can navigate family dynamics that may occur in a stressful situation. Um, I really liked to, I love that, Kim, that you and your brothers were able to come together on one thing, but I also know it was still a difficult decision, right?
Yeah.
So we just want to make sure that somebody's able to really get in there and navigate and kind of, de-escalate situations that might occur. So some additional documents to consider. And so those are your two majors, but you might want to also consider talking to your doctor about some additional documents. You may be familiar, you probably are, with a do not resuscitate, DNR. Some healthcare systems have now started calling this an allow natural death, and it really means the same thing. Some of the research that I was reading about said that the switch just comes from, it's a little bit easier to say yes than no. So when you say, do you not want to be resuscitated? They found that people have been able to say, do you want to allow a natural death? Yes. Rather than saying, do you want to be resuscitated? No. So that's kind of where that came from. But that's really all it's doing, is it's allowing a natural death. So this form is helpful if you're hospitalized, and this would be if something were to happen to you while you're in the hospital, and your heart or breathing should stop, that you would not want to be resuscitated. So this would be, talk to your doctor about it if you're going in for surgery or something. Um, so, but it's kept in the hospital and in your file. The pre-hospital medical care directive, or the out-of-hospital DNR, is for when you're not in the hospital, which is actually when most CPRs take place. So this informs emergency personnel outside of a hospital setting that if you're breathing or your heart stops beating, that they allow a natural death and not start CPR or use any other equipment, drugs, or devices to restart your heart or breathing. So if you're seriously ill, or if you're elderly and this is something you'd be interested in, you can talk to your healthcare provider about it. And then just to kind of go over, I have a friend who's a hospital social worker, and she told me, I was doing like an advanced care workshop with her, and she was like, I want, in Arizona, it's on an orange sheet of paper. And she's like, I want that orange sheet. And she's 28 years old. And I was like, Elena, like, I don't think you want the orange sheet. And she's like, I've seen what CPR does to people. And I was like, I'm glad that you understand that, because I think that, sometimes we see it in the movies and it just looks like really heroic and everything is fine. So CPR can be very beneficial in some situations, but it can also cause complications. The chest compressions can fracture or break your ribs. It can break your sternum. And then also brain injury can occur after cardiac arrest. So complications can vary based on a person's age, their current health, and then also how long it takes to resuscitate the heart. So again, having a conversation with your healthcare provider, you can ask them these questions. I'll go over later some questions that we have a resource that will help you ask your doctor some questions to get the answers you want. But really have that conversation with your doctor if it's something you think you might be interested in. So a physician's order for life-sustaining treatment, this is called a POLST. And then in different states, they might be called a MOLST or MOST, and that just is like a medical order for life-sustaining treatment. But this is for people who are seriously ill or frail or elderly people, maybe someone that you would expect that they may, not be alive within a year. So after having conversations with your doctor, you'll go through, it's more than what is in the DNR, and it's more about different medical and life-sustaining treatment options, but it will be a medical order. And this is completed by your healthcare provider, and then it directs other healthcare providers what kind of treatment you want or don't want. And then the person keeps the original, and it's recommended that you print it on like a bright pink or fuchsia paper, and you can put it on a fridge, but you can also make copies of it. And wherever you go as the person, you should bring this post with you. And it's signed by the healthcare professional. And then I also was looking into some research on this. And what I've kind of seen is, from what I recall, is 90% of people that have a post, they're honored, which is kind of a lot more than I think with the DNR, because again, when it's an emergency type situation, it can be hard to, act quickly in the ways that a person wants. So a post is an addition to a living will and the healthcare proxy. It does not replace it. In some states, a post will replace your pre-hospital medical care directive or your out-of-hospital DNR. So we know that nearly 50% of older adults die with some form of dementia, yet the standard advance directives don't address the complex and unique needs of a person living with dementia. So if you have been familiar with Compassion and Choices for a while, we've had a dementia values and priority tool, but we just launched our newest version. So I really encourage you to go check it out. But this is a free online tool on our website, and you can print it in the PDF form as well and fill it out by hand. That helps you determine, based on your values, what kind of care you want when or if you're living with advanced dementia. So this will become a dementia healthcare directive, and you will add this as an addendum to your existing advanced directives. This will help your medical team, your loved ones, and your caregivers understand your wishes. So again, after you print it, it's important that you provide this to, your loved ones, your healthcare team, and your doctor, and then attach it with your advanced directive, and have the conversation with them to explain it to them exactly what your wishes are. So this document is relative no matter what type of dementia you are living with. And then we also recommend that it can be helpful sometimes too if you make just like a short 5-minute video kind of outlining your preferences as well. Because again, it can be having those conversations and hearing it in your voice can be really helpful in directing people about what the kind of care you want. So also in the book, the toolkit, we have a My Particular Wishes form. So this is also another addendum that you can add to your advanced directive, and it states your wishes regarding specific life-sustaining therapies. So I think sometimes during the conversations I've had with my friends, again, when I do these, is that when you're looking at like, do I want to be on a ventilator on the living will, it will say like yes or no. And most of them feel like they don't want to fill it out because they don't want to say they don't want treatment. Because what if it is that they do want the treatment if it's going to improve? Most of them don't want to receive the treatment and have their quality of life, completely diminished. So this form can be really helpful for this. So you can mark if you want yes, no, or trial period. Like I want to be on a ventilator temporarily, and if it's improving my health, then keep me on it if you can remove me from it. And then if it's not, then I want to be discontinued from that service. So that's also in that workbook if you want to check it out. And so now I'm going to talk about end-of-life options, but I do want to point out that this is not really about planning for your death. It's really about planning on how you want to live your life based on your values. So the first option on there is, and these aren't in any particular order, but you can pursue some or all treatment available. So you can take medications and choose not to have surgery, or you can, try diet changes or physical therapy without receiving any sort of aggressive treatment. So that's always an option, is that you can pursue some or all treatments available. So palliative care is specialized medical care for people living with a serious illness. And it consists of a care team that often includes your physician, nurse, social worker, chaplain, pharmacist, and other trained specialists. Palliative care is based on the needs of the patient, and it really focuses on symptom management. And you can also receive palliative care in addition to curative care. So while you're still seeking treatment for your serious illness. The care team can also work with your caregivers and provide them with education and tools. And this has also been shown to reduce stress and burnout on the caregiver. Examples of palliative care could include pain medication or massages that's caused from pain by the treatments that you're receiving, spiritual or emotional support, or physical and occupational therapy. Palliative care is appropriate for anyone of any age, and it's also available at any stage of the illness. So, in fact, it's estimated that only 11% of people receiving palliative care may be in their last year of life. Palliative care is often covered by insurance. However, the length of time and the services offered to each person can vary depending on what insurance you have. So, hospice is a service that provides compassionate care at the end of life. The patient's primary care physician or another doctor makes a referral to hospice. Following a determination, the patient will most likely die within the next 6 months. And the goal is to maintain or improve quality of life. It involves an interdisciplinary team of caregivers that often includes doctors, nurses, home health aides, social workers, chaplains, trained volunteers, and others. Most people, when they enter hospice, also they stop seeking any sort of curative care. So this is really just about maintaining and improving your life, not seeking any sort of additional treatments for the remainder of your life, and just receiving comfort care. For people who have an appropriate medical referral, the cost of hospice is covered by Medicare, Medicaid, VA, and third-party insurance. And hospice can take place wherever the person resides. It's most often in the home. Hospice also provides bereavement counseling, family support, and end-of-life planning. And I just really wanted to, because there can tend to be confusion around palliative care and hospice, because a lot of the services and really kind of the meaning of it are both very similar. It's really to improve your quality of life in both of those. But again, hospice is for when you have a diagnosis of or prognosis of 6 months or less. And palliative care you can receive at any time once you receive a diagnosis of a serious illness. Stopping or refusing treatments. So you can always also make the decision to stop or refuse treatments and instead only seek comfort care. So if you are taking heart medications to manage, a chronic condition, you can stop taking your heart medication. You can also stop dialysis. You can stop blood transfusion, and then you can also forego treatments. So if you get pneumonia, you can choose not to be treated for your pneumonia and just receive comfort care, and then you would die from your pneumonia. Voluntary stopping eating and drinking. The acronym for that is VSED, if you've heard it. So this is an option that is legal in all states. So an individual who still has their decision-making capabilities can choose to voluntarily stop eating and drinking to allow for a natural death. So while this option is legal, it is important to know that not everyone is supportive, and this includes some healthcare providers and hospices. It's really important to have a supportive team if you choose this option. Your support team could include your loved ones, families, friends, end-of-life doulas, physicians, and hospice. The person choosing to do VSET can select the people in their life who are supportive of this choice and surround themselves during this process. As the process continues, the person will need their help for self-care. A supportive physician or hospice can also provide palliative care during this process to make the person more comfortable and help manage any symptoms around thirst, and also just the typical process when somebody is at the end of life, all the typical symptoms that might come up. Reasons why people cite that they choose this option are often from intolerable suffering of a terminal illness, unrelieved suffering of a chronic or incurable progressive disorder, or just choosing to complete a fully lived life. We have another storyteller who shared that he was 99 years old and his wife had passed away and like 5 years earlier, and he had always lived independently, and it was at a point in his life where they were going to have to move him into an assisted living facility, and he decided, I'm 99 years old, I have lost my wife, I've lived a wonderful life, and then he decided to do voluntary stop eating and drinking because he didn't want to go into the assisted living facility. And it can really be a meaningful way too, because during this process, you get to say goodbye to all your loved ones as well. Palliative sedation, this is sometimes referred to as terminal sedation, and this is an option that is used in rare circumstances. Typically, pain medication and sedatives are given to patients, but if that's not enough, then your healthcare provider will talk to your healthcare proxy, your family, and you about possibly palliative sedation. This process does have to be medically managed, and the person also stops receiving nutrition and fluid at the same time. I do just want to point out that palliative sedation is different than just giving a lot of pain medication at the end. When somebody receives a lot of pain medication, they can drift in and out of consciousness. When somebody is going through the process of palliative sedation, which is usually pretty quick before their death, the goal is to make them completely unconscious and try to take away the pain, and which is successful in most instances. So medical aid in dying. So this is a practice that allows the terminally ill adult the option to request medication from their healthcare provider to receive medication to peacefully end their suffering. So this practice is authorized in 10 states plus Washington, D.C. So all the blue states up there is where this is authorized. To be eligible for medical aid in dying, an individual must be an adult, so over the age of 18, be terminally ill with a prognosis of 6 months or less to live, which is the same as hospice, be mentally capable of making their healthcare decisions, and then be able to self-ingest the medication. So this is medical aid in dying is authorized by states, and so each state has those basic requirements. However, the laws kind of vary slightly as like to who can prescribe, how long you have to wait between making your first oral request and your second oral request. And then there's some residency requirements in a lot of the states. Oregon and Vermont do not have residency requirements. So a person could travel to those two states and go through the medical aid and dying process. But I do want to point out that it is not legal to go through the process, get the medication, and then take it back to your state. And then I also just wanted to point out too that for the people that do request medical aid in dying, it's completely optional. It's optional for healthcare providers, healthcare systems, and a person to request it. And what research has showed us is that 36% of people who obtain the prescription never actually use it, but their families have reported that just by having the medication has allowed the terminally ill person to live out the remainder of their life with less anxiety, knowing that they had this option if their suffering became too much for them. So again, it is important to have conversations with your healthcare provider about the care that you want and that you don't want. Medicare will allow reimbursement for advanced care planning conversations and allow time for a conversation to happen with your healthcare provider regarding end-of-life care. So earlier I mentioned a questionnaire thing that we have as a resource, and this is available online. It's just called the Diagnosis Decoder. We have one for general illness, cancer, and dementia. And this will help generate specific questions based on what you mark that you want to find out. that you can go in and ask your doctor. And these questions are designed to help you get the complete information, um, because you know best what it is you want, and some of the questions on this, might be, I'm really familiar with the dementia one. And I know anytime my grandmother was moved, she was always, even with her late stage Alzheimer's, she was always a very nice person, unless you moved her to go get a test. And then it was like, she would just get so confused and so disoriented and didn't know what was going on. And so, like, one of the questions under the tests or under the dementia one is, is this test necessary? What happens if we don't get the test? Because if it's just a basic test that's not really going to improve her life, her quality of life, or extend it, then maybe we skip it if it causes more harm than good. And then again, I know I've talked about this, but I really just want to drill it home, because it is so important. Having your advance directives written down is only one step. Having conversations with your loved ones and your healthcare proxies are key. Conversations allow you to clarify your wishes. A hospice nurse recently shared with me that she often hears people say, in the house or in the bedside, remember when mom said this, or remember when mom said that. People, especially in a crisis, it's really easy for them to kind of recall those kind of conversations. Conversations are key. So now I just want to talk about tips for conversations. So sometimes loved ones are hesitant to have these conversations. And so in our toolkit, we have in the advanced planning toolkit, we have tips on how to start these conversations with your loved ones. There's lots of holidays in the month of December. And sometimes Thanksgiving is a great time to have these conversations with your loved ones. Um, and there's just some gentle ways to say it. My mom started trying to have these conversations with me in probably 2016, 2017. And I didn't want to think about anything happening to her. And just was like, no, I don't want to hear this. And she lives in Michigan. So, like, I would go to visit her and she'd be like, oh, like, I want to show you all this stuff. And I'm thinking, like, no, I just want to spend time with you. I don't want to have to go over these documents and do like businessy stuff. And it is really important that I know what my mom wants, because she's also my sister's guardian. And if something happens to my mom, then I take over that. Um, but so she was a nurse and she retired when she was 70 years old in 2019. Um, in and then right after she retired is when we had the COVID-19 pandemic. And she was getting emails from the hospital, saying that they would pay her $5,000 a week for her to come back and help out. And, this was during a time when the hospital staff didn't even have personal protection, when they had run out of all that stuff. And so that really changed my mind on thinking about how to have, I do need to find out what she wants. Like, it is a possibility that it is not just a possibility. One day my mother will die. Um, but so you can try and have the conversation. And if people are not super receptive, I would just encourage you to keep trying, because now my mom and I have had lots of conversations around it. So really just keep trying. The more you talk about it, the more the stigma reduces from the conversation. So it's also important, again, as I mentioned earlier, sometimes, based on culture, um, or, you know, what you value and what your priorities are, sometimes it can be hard to find out what your loved one wants. Like, I want to know what my mom wants. And I've asked her a bunch of questions that she hasn't even thought about since I've started working with Compassion and Choices. Um, and I was talking to somebody and she's 44 years old and her father is 87. And she is a volunteer with us. And she said she asked her father, who was 87, what he wants. And he responded to her like, well, I'm just going to live forever. And so, sometimes your loved ones are even hesitant to have these conversations with you. So I just wanted to give you some tips about it, and you can start off simple. So I feel like an easy question is, how would you like me to remember you after you've passed away? Like, if you like rituals, or like if it's your birthday, how would you like me to celebrate you? If it's, the anniversary of your death, a lot of times loved ones will get together. So find out that kind of questions. Would you prefer your doctor give you direct, honest information about your health, or give it to your loved ones so that they can share it with you gradually and you have time to digest it? So sometimes when a doctor gives people news, I know people like this, like as soon as they think, and I'm kind of the same way. I think I'm going in for a regular appointment and my doctor tells me that I have a new diagnosis, and sometimes it can be shocking, and I had this experience and I just kind of blacked out once I heard him say something. um and so sometimes you may want to hear everything, or sometimes you might want to have the other person hear something and then break it down to you. In my experience, my doctor knows me pretty well. So he told me, don't Google anything, and I'm going to give you a fact sheet, like a information sheet about it. And what I did is I left the hospital room and I called my friend and I said, I want you to read over this and I want you to Google all this information and then tell me if it's as bad as like I think it is, which it wasn't. Um, but sometimes hearing information can be shocking to people. So that's a really great question to ask people. So key takeaways. Advanced care planning is one of the biggest gifts you can give your loved ones. Identify what's important to you. Document your wishes. Talk to your loved ones, your support systems, and your doctors about your end of life wishes, and talk to your loved ones about their end of life wishes. As an additional resource, we also have joined a partnership with a nonprofit called Free Will. And so this is to create a legal will, and this is free to you. If you go on this link, and we'll send it out in the email, to create a legal will, which is different than your living will. So nearly 70% of Americans don't have an updated legal will, and everyone's encouraged to have one completed, regardless of your wealth or where you are in life. And so this typically, I think people think of a legal will as dealing with distribution of property, but it also lets you address several important items, such as, designating a guardian for your children or your pets, setting out your funeral and burial wishes, and then also creating a digital executiveship, so someone can handle your digital assets after you've passed. So this takes about 20 minutes to go on, and you can start and stop it. I've done it several times. Um, and, um, and then you print it and keep it with all your important documents as well. And then I also just wanted to mention our Staying Stronger Together webinars. So these are recorded webinars that Compassion and Choices has done, and it's just on this website, which we'll send out in the link as well. But you can go through to at your leisure if you're interested in finding out more about like what a death doula is. We have webinars about that, how to process grief, what hospice is, what palliative care is, a whole bunch of information you can find on there that can also help prepare and inform you with information. And then lastly, if you want to get involved more in Compassion and Choices, first step, if you haven't done it already, I would definitely recommend completing our End of Life Decisions Guide. At Compassion and Choices, we really, really count on our volunteers to help us out, and our volunteers are amazing. We have volunteers all across the country because, it might seem like there's a lot of employees, but there's few of us compared to how many Americans are really out there. And so the more volunteers we have, the more we can work on getting this information out, and really, changing the way our healthcare system is, changing the way that people are living at the end of life, and really being able to honor people's wishes. And then Compassion and Choices is also funded almost exclusively by individual donors who are committed to the issues of end of life care and choice. So if you are able to, please consider making a donation today. Any amount, little or small, helps us to expand our work so that everyone's priorities and values are met at the end of life. And you can donate just by going to compassionandchoices.org donate. Thank you. And you want to, we can ask some questions now. So one of the questions was, how would you apply this information if one is traveling or living in another country part-time? So I would take your advance directive that you have, but really healthcare systems, depending on what other country you're going to, healthcare systems can be very, very different. And the end of life options available in other countries can be different. So if you have your advance directive, and you're just traveling to another country for a couple weeks, it would be helpful for you to let people have access to it so that they understand what you want. But if you're really spending a lot of time in another country, I would find out what that other country's healthcare system is like. And if they have their own advanced directives, some other countries also do. So it really depends on where it is. But again, it's the whole healthcare systems are different country to country. So it's important that you know the laws of the country that you're spending part of your time in. Another question was if this recording will be on the Compassion and Choices website, because they were a little late to the meeting. So the whole thing was recorded, and we'll send out an email with the recording. But I think that will be available on line 2. And then, do you have resources for adults with intellectual disabilities to help them plan for their end of life wishes? What I would suggest doing in that case is if you call our end of life consultation program, I'll send that out in the email as well. But we have end of life consultants who will help you navigate through, different healthcare systems, different end of life options, different, questions you may have about advanced directives. And all you do is you just call the number. And they'll call you back within, like 1 to 2 business days, or you can email them and they'll get you information. And then, is it recommended for an end of life doula to become a health proxy for individuals that they are working with? I think it's really up to the person who's choosing it. I know that I don't feel like equipped necessarily to answer that, but I do know that there is a we do have an issue with what is known as solo seniors, which are people who don't really have a support system, and whether or not they who they're picking for their healthcare proxy. So we always recommend that people at least fill out their advance directive and share it with their doctor so that their doctors know. But yeah, I'm not sure what the best practices would be for end of life doulas as far as becoming a healthcare proxy. If you want to send me an email, I can see if somebody else knows. So you'll get my email when I send out the email as well. And then may we share this Zoom recording with others? Yes, please do. Again, the more we can get this information out there, the more conversations are had. Really, our goal at Compassion and Choices is that just everybody have an end of life experience that they want. I am so glad that Kim had that experience with her mom. And I really love the story of how the doctor sent her the note, because the doctor is right. Like, I know so many people that have just had just such traumatic end of life experiences with a loved one, because these conversations didn't happen. Let me see if there are other questions. So my sister is my healthcare proxy. However, she lives in a different state than I live in. Should I consider choosing a healthcare proxy who lives in the same state? So sometimes that would be a really good option. Again, it depends on who you have in your support system. But like, if a crisis occurs, it can be helpful to have somebody that's close by that can get to the hospital and make those decisions right away and talk to the doctor. But it really depends on who you trust the most. Like, if you trust your sister the most and you know that she's going to carry this out, that's good. But I also have people that maybe their healthcare proxy is in another state, but they tell all their neighbors. We have a lot of people, a lot of our supporters with Compassion and Choices think about this a lot. And so they tell all their neighbors, they tell their doctor constantly. They just tell everybody all the time what it is they want because they want to make sure that they get it. And I think that may be all for the questions. Okay, and I do see that somebody said that unfortunately they don't have a support system and that they're what would be called a solo senior. So again, I'll give you the end of life consultants line, the phone number and the email address for them and the follow-up email, and they can kind of try to help you navigate that. So. Okay, well, I want to thank everybody so much for taking the time to join us today. I know it's a busy time of year. Kim, thank you so much again for sharing. Your story really stuck with me when I heard it. So I hope that it stuck with other people and that it really encouraged some of you to have these conversations. So this really is one of the best gifts you can give to your loved ones. Thank you.